Okay, I think we'll get started. Welcome everybody. My name is Sean LaFrance. I work here at the Foundation for Healthy Communities, and I know we have the hospital case management folks as sort of a core group that was meeting and talking about this stuff, but I welcome all the folks from the department and some other guests. And then we have, I understand possibly 20, 25 other people remotely participating. The origin of this in terms of our engagement and working with the department is a project we did earlier in the year where we looked at the issue of people who are in hospitals who are medically cleared for discharge but unable to do so, unable to be safely discharged. And among 21 hospitals in a 3-month period, we documented over 550 folks in that situation. And there were a number of barriers related to that, certainly housing issues, mental health, decision-making, capacity. But a significant one was related to insurance and people's ability to pay for care that is not in the acute care setting. And certainly the Medicaid application process is a critical part of that. So we've been working really closely with Mickey and others at the department to try to spread the word, and they've been doing a lot to, I think, simplify or clarify some of their processes. So that's really our core function today for this particular training. So welcome, and Mickey Grimes and Karen Carlton from New Hampshire DHHS. I'm going to pass around just a sign-in sheet if you would.
I did.
Oh, you've already got one going?
Yeah, I'll give you a copy of it when it's done. Or
Okay.
you can give me a copy.
Yeah, I can go
How's
make
that?
a copy when it's done.
You have to excuse me because,
Excuse me.
I don't know, maybe Scott hit me in the nose.
Do you need it?
Yeah, Scott?
Yes,
I want to thank New Hampshire Hospital Association for letting us present this training on the medical assessment form today. And I want to thank Scott Trudeau from New Hampshire Care Path and the Balancing Incentive Program, which is a grant that we received from the federal government, and he works for UNH. He's not the guy I just found at Panera drinking coffee.
Although you just missed me. I was there 20 minutes ago.
And he has put together this presentation. Now, this is not a PowerPoint. It is actually a web presentation that we are going to put out on our website so that people can self-take the training. And now for the individuals who received the presentation packet the other day from Ann, we have changed some of that packet as of last night. So, the department is constantly making changes. So for the MEA, we have changed the form so it's now 2-part. The first part of the form has to do with the medical eligibility. The second part of the form really has to do with care planning. And we have added some information to that. So the ones that you received 2 days ago via email is not now the correct version. Ann and Sean are going to send out the updated versions of that. So with that, I'm going to introduce Karen Carlton.
Well, thank you all for coming. We've been working on the medical eligibility determination tool for, the past few months, trying to enhance it so that we get comprehensive assessments and also to make it a little bit easier for people to complete so that the questions are pretty much sort of black and white. We sort of tried to take out some gray areas that people had stated that, were some of the difficult spots. As I speak, Scott is going to go through the screens, and you do not have a new instruction booklet yet. instruction booklet was not completed due to the last minute changes. So that is going to be uploaded to eStudio next week when the new forms go out. So if you want a copy of that, you'll have to take that from the eStudio next week. But we're going to go through the changes today and talk about why we did those changes and how to complete the tool for people looking for medical eligibility, either for nursing facility or choices for independence. Just a reminder, this is the same tool that we use for both. So we tried to divide it between medical eligibility and care planning purposes. They thought that the care planning, and it makes more sense when you're going through the tool that we can actually look through the first part and see if the person is eligible. And then if you do choose for choices for independence, we can look at the second part to see about identifying a preliminary service plan. I didn't introduce myself, but Mickey said Karen Carlton. I'm the long-term care nursing supervisor of the medical program. Your responsibilities when you're doing the assessment is to collect the data for the department. That is basically what we're looking for when you're doing these assessments, and it's to determine the eligibility. So when you're out there doing them either in a facility or in the community, we're asking for you to engage other people that are involved in the care, whether it be family members, any other caregivers that are involved, any of your agencies that are providing care, and then in the facilities, anybody that's been involved in their care while they've been there, being the nursing department, the therapy department, and the medical social workers. Just as a reminder, we have expanded with Senate Bill 49 so that the eligibility determination tool can be completed by other parties now, meaning that other qualified health professionals are able to do completion of the tool. And that is, as it states in 42 CFR, they must have at least 2 years of qualified training in the assessments. And it normally covers the medical doctors, the nurse practitioners, physician assistants, and anybody in the therapy world that has completed that advanced training and assessment. The social workers, it states as a master's level social worker to complete the assessment. We will be accepting them from those parties if they've gone through the training, either live or when we post the training up on the website. We will be accepting the assessments. And some hospitals have already started to do that. They've already got other people engaged to do the assessments. Confidentiality requirements. I'm having trouble reading that, Scott. It's crucial that all information gathered from any source is treated as confidential. You know, our HIPAA regulations. No information can be divulged by an assessor in any way that would serve to identify any individual person. So be careful when you're out there. Lots of people are asking for information, you know, why you're there, what you're doing, or whatever. Could be people in the building, could be other people that come to visit. Just be careful about giving out that personal health information to anybody. Make sure that they are qualified to be receiving that information. Preferably, we would like to see the guardians be there, the durable power of attorneys, but I know that's a challenge for a lot of people doing the assessment. It doesn't always happen. On the MEA tool itself, what we classify as the header is the very top of the tool, and it's got the last name, first name, middle initial. MID number is the Medicaid number. Please don't put in Medicare, Social Security, or any of that. That's not the number we're looking for. If you don't have a medical identification number from Medicaid, just don't put anything. Okay, and then we'll look up the person. Because it's confusing. Some people are putting in their New Hampshire Healthy Families numbers. Some people are putting in their date of birth all together, and we're trying to decipher what that number is. So please try to be careful and not use those numbers. Okay, so now we're going to go through the MEA tool page by page to review the sections. The first section we're going to go through is section A, professional nursing services. This section is usually where most of the information is gathered when you're looking for a short-term stay under Medicaid, or that they have skilled services that require a professional person, either nurse or therapy. And that's what this page means. So if they're in your facility, waiting to go to a facility for rehab, most of your information should be on this first page. They should have some rehab listed or a projected plan for their rehab. And if they have any skilled nursing besides that, you would want to put it on this page. If we go to the second page, we didn't make any changes on the first page. If we go to the second page, the second part is section B, special treatments and therapies. This is more chronic in nature. This is more of our long-term care population that we see. And this is where you want to list the chronic conditions. Now we have made some changes here that have enhanced some of the sections. So what we did is we added wound treatments. I know it used to say before, barrier dressings for stage 1 or 2. We're not going that route anymore. We just want to know any wound treatments that they receive at all. So if they're on a wound vac, if they're receiving any type of wound treatment by the provider, this is where you're going to put that. We also added venous puncture for disease and or medication management. This is for our Coumadins, our PTINRs, our Clozaril on some of our mental health population. If they're on seizure medication, it could be their levels for that. Anything that requires somebody to have that venipuncture that related to their disease is where you would mark it here. The other part we changed is under chest PT. We took out by RN. Chest PT can be done by many different entities now, and we took out RN. So if they are involved in that, you have a section to use that. We also did oxygen therapy. A key point here is for chronic or unstable condition. That's when you would classify it on this section. If they were in the hospital and they were started on oxygen and you know that's brand new as of that hospitalization, then it would be on the first page. If they've had the oxygen therapy for years and they have chronic COPD, emphysema, any of those conditions, you would state it here. Now, when we talk about oxygen therapy, we talk about, is this person able to independently manage every aspect of that therapy? And they change over to a portable tank if they have to. Do they monitor it for, when they get their deliveries? Do they change their tubing or take care of it appropriately as identified by the company? Do they call the company when they have problems? Do they know the 24-hour number? Those are what we're looking for. If they cannot meet all those requirements, then they do need assistance in that area. Okay? Now, it can be a monthly assistance by the company. That's perfectly fine. And where it says specified, you can put the company name in there. I'm sorry. If, and that's acceptable. Or if they have a weekly nursing visit and the nurse is monitoring that, maybe taking their, their oximetry, or making sure that they have enough supplies, or making sure that they're safely using the oxygen, you would put that there. The other addition here is we added disease management for diabetes. I cannot tell you how many assessments we have looked at that the person is non-compliant with the blood glucose. They don't call the doctor for foot care. They don't get their eyes checked. You know, without someone prompting, supervising, and cueing them to do that, they wouldn't do those things. So that is an addition that we put in. Again, we gave you the same categories to monitor, so that, you know, if the nurse is doing those things, then that's, you know, something that we would want to have identified here. And again, next to specify, you could put in what the nurse is doing, or what the person, could be another caregiver, is doing to make sure that those needs are being met. Diabetic nail care. You know, sometimes they're getting that under our program and not under Medicare because they don't have Medicare. So that isn't identified. So those were the changes we put in the treatments, chronic conditions, so that we could capture as many of those things as possible. Under the question number 2, treatments and procedures, we did not change anything there. We did not change anything in the pain and pain management. You'll notice the pain and pain management, the time frame is over 7 days. The reason we left the pain management here is because it kind of goes along with all of the other needs under the medical component. But usually the pain management we look at for when we're developing our care plan also. Is this person got chronic pain? Does this person have acute pain? You know, is somebody doing something to help that person with that pain, so that it can assist them on the other side of their ADLs and IADLs. We go on to the mini cognition section. I didn't make any changes to question 1, 2, or 3 under question 1 part here. We're still asking for the clock. So we give you the pre-drawn circle, and you're going to have them fill in the 11:20 as the time. And we ask for the repeat of the 3 objects. When I was doing my research for this, I looked at MDS and I looked at OASIS, and they signify short and long-term memory. So in your assessment, you could probably incorporate both by doing a short-term memory within so many minutes, and then maybe at the end of the visit, see if they still remember those 3 words, so that could give you some indication when you're looking at the identified needs for where they fall in that cognitive impairment. The biggest change in this section is that we changed the daily decision makings. If the person falls in the category of independent, they must be alert, oriented, able to focus and shift attention, comprehend and recall task directions independently. That is a tall task for some of our clients to do. So then we moved into modified independence, and we put that in with requires prompting, which is cueing, repetition, reminders, only under stressful or unfamiliar conditions. We feel that most of our population, they can go about their day-to-day, but if you put something abnormal into that day, it is probably going to cause them some cognitive impairment. And that would give them a scoring for cognitive impairment under the eligibility. We also talk about the moderately impaired. We put this in requires considerable assistance in routine situations, is not alert and oriented, or is unable to shift attention and recall directions more than half the time. We put it in as is not alert and oriented or is, so that they can be either or. And then totally dependent is due to disturbances is constant disorientation, delirium, or inability to make daily decisions. They are totally dependent. That's probably the significant change in this section because we were seeing that a lot of people were clicking off independent, but then in the nurse's note was telling us a different picture of the person. So this way it gives you the chance to identify it here, and then you can elaborate later in the nurse's notes. But if it's identified here, it will go on your needs, identified needs section. We also took out, it doesn't need to be nursing to manage these symptoms. It can be just monitoring supervision of anybody. It could be family, it could be caregivers, it could be neighbors, it could be the daughter calling every day to make sure that they get their meds on time, that they take, they have their meals. Could be the Meals on Wheels driver who's going in every day to deliver the meal, making sure that, they're doing what they need to do and that they're not unsafe. Any questions about the cognitive section? Then we moved the physical functioning structural problems. Oh, Scott's in the clock. Okay, we'll talk about the clock.
We don't have to.
Is everybody familiar with the clock? You get the pre-drawn circle. The person is to identify the time. And then, you have them put the numbers on the clock, and then you have them identify time. If you're doing redeterminations, you might want to change your time. There are certain people that remember year to year, so the minute you pull it out, they automatically know. If they have no cognitive impairment, they know what's coming. So you might want to just move it around a little bit. That's okay to do. You don't have to stick with what the instructions say, but please put it in your nurse's note or on the clock drawing what you did, just so that we know that it's okay. And then you'll get some people who want to draw grandfather clocks, and they want to put it, or they want to put digital time, or, whatever. We have some clients that like to be creative. Okay, now we're on to Section D. Section D is the new section of physical functioning structural problems. We have moved the ADL section to here because that's part of eligibility. I've always usually said that this is the largest component for eligibility, and it still stands that it is, because under the requirements in the RSA, they must meet 2 or more ADLs in order to be eligible for the program. You will see that I took some of the components out of this section because it really didn't need to be here. It wasn't a place for it, so we moved it over to a care planning side. Excuse me 1 minute, let me find my section. Okay. So when we talk about this and we talk about independent, I want to just review the self-performance and then the support needed. When we talk about independent, that means that this person can actually complete the whole activity without any help or oversight. They can do every single part of it without any assistance. That's independent. People are interpreting independent as if they're saying, well, yes, I do that, but there are some components of it that maybe they aren't doing. Like you notice they don't have shoes on. Is it because they can't put the shoes on, or is it because they choose not to wear the shoes? That's a question you need to verify when you're doing the assessment. The other part is some women who have difficulty dressing lower body may just wear a one-piece dress type. Is that because they can't dress their lower body and that's what they wear to accommodate? So they would need assistance to dress their lower body. And we need to make sure that we're capturing that accurately in the assessment. Supervision is oversight, encouragement, or cueing provided throughout the activity. That means that they must have somebody standing by through the activity, cueing or supervising the steps that they're not doing. And that's what we're doing. And that is 3 or more times. And you look at this within a time frame of 5 to 7 days. MDS says 5, OASIS says 7. So I say 5 to 7. That gives us a good time frame. The other part of it is limited assistance. And that's classified as the individual is highly involved in activity, received physical help and guided maneuvering of limbs or other non-weight bearing assistance. And that means that it's provided at least once throughout that 5 to 7 days. That would be classified that they would meet that requirement. Extensive assist is that they performed part or minimally part of the activity with the help of the following: weight-bearing support or staff support provided 3 or more times. That's real important, those classifications, when you are checking off your boxes. The other part is the ADL support. If you have a check-off box, oh, there's a typo, I'm sorry. We'll fix that. If you check off the supervision box, you probably aren't going to check off no setup or physical help from staff, because supervision, as you remember, is can be prompting, cueing, following them out throughout the whole process. So if you're checking off your self-performance boxes, please make sure that your support boxes match. We have a lot that don't match. We'll get one person physical assist, but yet you have independent. So sometimes if you're doing your assessments on the computer and you're not erasing or somehow it got saved differently, just make sure that it's matching before you send it in so that we can go forward with it. There's a tool that the MDS uses, and it's called Activities of Daily Living Assistance. And it's sort of an algorithm that the MDS manual has set up that I thought was very informative and could be very helpful, and we probably are going to try to implement this as a worksheet form for people to use. You don't see it on your screen, I'm sorry. It's something that I looked at, and it really talks about the instructions for Rule of 3. And it talks about when an activity occurs 3 times at any one given level, you're going to code that level. And I think we need to remember that when we're looking at it. So if they have a daily person helping them to take a shower, and they need that person every day to take that shower, then they exceed the Rule of 3 times. So that you would want to look at, they need assistance for that activity. Again, if the activity, the resident fully performs the ADL activity without any help or oversight from the staff every time, then you could classify them as independent. But if the resident requires a combination of staff performance, weight-bearing, and or non-weight-bearing assistance 3 or more times, you would classify them as limited assist. You see how they look at it as classifying the assistance. And the reason I'm going over this so much is we get a lot of assessments that have zeros. And we're having a hard time trying to look at whether the person is actually, especially on redeterminations, whether the person is utilizing that personal care support for those activities. Because it looks like they really don't need that much support if you're looking at the assessment for face value. So what we're doing is we're trying to get some extra information to help us with that. Or look at your comprehensive note that helps us, which is time consuming because we would like to be able to get that eligibility approved and move the client through the system. So that's why I'm sort of taking the extra time to go over this now, so that maybe you could look at it as the Rule of 3 and see if the person meets those requirements. So again, remember, it could be in that 5 to 7 day range, and if they need it at least those 3 times, then they'll meet the requirement. And then we move on to the bladder and bowel continence. The MDS and the OASIS, again, look at this as within the last 5 days. And they look at usually incontinent, and we wrote episode once a week or less, and they look at it less than 5 episodes. So I'm just trying to give you another parameter to look at. They classify them as usually incontinent. If they're always incontinent if they have no episodes of continent voiding. So that would be the all the time or almost all the time. Or even if they go one time, you know, they make it. They still classify them as incontinent. Remember, the 2 out of 5 ADLs that we take are the transfers, eating, dressing, toilet use, and bathing. The other 2 are incidental, bed mobility and personal hygiene. We also will take incontinence as an ADL if it's one or the other. Underneath the appliance and program section, that's sort of information for us to know as part of care planning, so that I left it with the incontinence so that it would flow for you, but we need to know what they use or what they need assistance with so that we can incorporate that in the plan. The next section is E and F, and we've moved the medication to this section. If you are sending in a completed medication list, you could do so when you upload your assessment, and you could just type in there C completed MAR or attached MAR or whatever you want to say, so that we know to look for that when we look at your other documents. Or you can type them all out here, which I'm sure some people are quite extensive. We allow facilities to send in the medication administration records also, so you don't have to type them all out. This is another section that we did a lot of changing to make it a little bit clearer when you're identifying if the person can actually do the medication administration. What we mean by the every aspect of that medication delivery themselves. Do they know how to get the medications called into the pharmacy? Do they get them picked up? Do they get them sent to their home? Do they get them, do they have checked to make sure it's the right dose, the right person, taking the right tablets? That is all part of medication management. And if the person cannot take the correct medication and proper dosage at the correct time, then they are not independent. If you are filling a pill planner or a Medi device, or the pharmacy is, then they are not independent, because they're only taking what's out of the pill planner most likely. So if you question them on their meds, or how do they get their meds, and who picks them up, and do they know what this med is for, you probably would get a very vague answer. Because a lot of people who had Medi planners are very reliable upon that Medi planner just being filled. They took that out of the equation of themselves, that they have to deal with that at all. So that means that they need assistance with that medication. So somehow we have to know that in the identified needs, exactly what is being done for their medication. Daughter is pre-filling. Pharmacy, is pre-filling. Daughter does pickup. You know, this is things that we need to know in the nurse's note or on the identified needs so that we know that that is something that's being taken care of. So question 1, 2, 3, and 4 is no medications in the last 7 days. Is the only questions that we are going to list under medication administration. I took out all the rest except for the self-administration. Do they do their own insulin and nebulizers and stuff like that? Because some people do. They've had them for a long time and they do fine with them. But it's most of the prescription meds that we're having trouble with. So that means if they are not under 0 independent, they're going to need assistance. And it should be identified in your needs section. Okay. Now, that finishes eligibility. As you see, we put a little line down there. Please be sure to complete Part B of the form, because we don't want you to think you don't have to complete the whole form. But when we're doing eligibility, the first part of the form is going to be the primary function for us when we're trying to let someone know that there's a person eligible for the program, especially when we're getting calls from our facilities and hospitals and whatever. It's going to be quick to go through and try to put all that together. The second part, Part B, is the care planning. So this is the new Section G, and all it does is it picks up with the communication hearing patterns that was, you know, way back in the front. I think it was page 3 of the old assessment, and now we're talking at page 6. And on page 6, it just sort of picks up with those things, and then it goes right into the next section of Section I, Mood. Now, this is the patient health questionnaire. Depression is very prevalent in our population, as you all know. We have a quality management that we track the answers from the assessment tool and how many people are scoring and if an intervention was done or whatever. And also, when the information is gathered here, our case management companies, when they're assigned, get this assessment. So it's real important for them to know that. So what I did is, this is the part I had to add last night, is we actually added the score now at the bottom of this section. When you're scoring this section, each checkbox, depending on what column it's in, gets points. So if you check off anything in the not at all line, those are all 0 points. If you check off anything in the several days, those all get 1 point. The more than half the days, and this is in a week now, gets 2 points, and nearly every day gets 3 points. So when you're calculating your total at the bottom of this section, please follow that guideline and calculate and put a total there for us. If you don't, we'll do it. But since you're there and you're going to do the identified needs, you'll need to know what that score is.
Karen,
Yes.
is this in the last 7 days or in the last 30 days?
7.
7 days?
I'm not sure if the people are going to be able to answer if we say 30 days. So
Right, but
we
I
may
read
go
it
across.
somewhere. I was doing 2 weeks, and then I read that it was 30 days.
Well, that and that was, in order to capture accurate data, we made everything sort of be the same within the last week. 30 days is what the old instructions did say. Yes. Any other questions about that section? Go back to the
Vision?
Yeah, no, go back to the mood. I saw one thing, I just wanted to, one more. Go down to the wording stuff. Keep going. It should be at the bottom. Yeah. If depression is identified as a problem, which is a score 5 or above, then it should be listed in the identified needs section. It needs to be there. Please. If they are on medication, if they already have a therapist, if they already see somebody else, if the PCP is managing it, however, we need to know with that score what's happening. We have not been getting that information, and it's very difficult to try to follow if a person is getting treatment for it, especially if we're doing our redos, if we don't know what's been happening. Now, if the person is resistant and refusing, that's a different story. But if the person is actively involved in treatment, then we need to know that. Problem behavior is the next section, section J. Problem behavior did not get changed. We left it the same. That is utilized mostly within our facilities, but there are occasional people in the community that have some of these. Again, if that is occurring and you're seeing that you're doing your assessment and you're noticing that there probably is something going on within the home you're in, we do have Adult Protective Services. And Adult Protective Services should be notified if this is causing a problem within that home. The reason I'm saying that is because we're all mandatory reporters. And when we're reading it at the office, we're reporting it. But it should be coming from you. You're there, you're seeing it firsthand. You got somebody that's threatening, you got somebody that, says, hey, she pulled out the knife out of the drawer at me. We need to be reporting that because they're going to be watching. Okay? Or I read one the other day and I was sort of like, oh my. The conditions the person lived in were just unacceptable. They weren't even standard conditions. There was no kitchen. There was no way for her to prepare food. Living in a basement. I think we need to report that. And so we did. But I would like to see it come more from those of you who are assessing the person since you're there and it's firsthand. And if you need that information, we'll be glad to put it out on our website, on the eStudio site. And it'll give you the contact information to call intake. And that's all you have to do is place a call to intake and say, I just left this home and this is what I saw. Let them do the decision making, but make sure that you report it. Any questions about that? Because I'd rather see it come from you guys that are actually visually there than us. But we'll follow up if it's not, if you say you didn't, for some reason or whatever, we will make sure that it gets done if we need to do it. I didn't change any other sections in behavior. We coded everything still the same. Again, we took out that it's nursing management. It can be anybody managing those behaviors, including family members. We'll move on, Scott, to K, environmental assessment. I'll just supplement. Environmental assessment. Again, this section should be as accurate as possible to what you're seeing. The reason we included this, we've had this in the assessment tool now for the last couple times. The reason that we include it is for those reasons that we want to know what the conditions are before especially on a new person, before we're sending somebody out there. Now, our facilities, our acute cares and nursing homes don't have the advantage of seeing them in their homes, but certainly you can get a feel for, with conversation, how they live in the community. But these are very important for us in the environment so that we know we can prepare people going in. Then we go on to the instrumental activities of daily living. These are all our homemaking activities and transportation. Our program is a medical program, and if you're going through the assessment and really this is the only area the person needs assistance, then most likely the medical criteria is not going to be met even if we get additional documentation. So this would be where we would want to make a referral to one of our other Medicaid programs that could provide them homemaking or Meals on Wheels services. And that is through our Title 20 and our Title 3B program, which most of the certified agencies in New Hampshire have availability to that. There is limited funds, I will tell you, but if we're unable to put the person on the CFI waiver, then we are having our eligibility coordinators through the Balance Incentive Program try and make a referral to one of those programs so that they can get assistance. If the person is eligible for our program, then these are incidental activities that can also occur. They can get this homemaking task, but we try to make them aware that we'd like them to have the personal care first and foremost, and then any of the other activities they certainly can have assistance with. We do not do medical transportation under this program. That is all a Medicaid service. So if they need medical appointments, please identify somewhere that they need that assistance so that the case manager who's going to be assigned and or we can help with getting them linked up with Medicaid transportation so that we can move them into that right program. The task allowance that is part of the activities of daily living is critical to us in trying to determine how much time they need in a week in order to do those tasks. So if you could please try to estimate or average out the time in the conversation with the person, is very helpful for us to figure out their time. We do have non-medical transportation, which is outside the medical care of the PCSP. There are PCSPs that do the medical transportation within providers. Those have to be prior authorized. So if the person is looking to go to church once a week, you could put that down as an identified need, and we would make sure that when it's assigned out to the case manager, that they would be able to help them get that set up. We also do escorts to appointments with prior authorization. So just a reminder, it's not automatically generated in the person's plan. We do have to know how many appointments and how often and how much time. We try to limit so that we had somebody who wanted to go to Dartmouth every day of the week, which was a very long, involved process. And we ended up working with Medicaid to try and work that out so that it wasn't so much time involved in that. The companies get reimbursed either by the trip or by the hour, depending on how they want to put in for the approval. They can't get paid to drive and to be the PCSP at the same time, though. They'd like to, but they can't. They either get paid for the trip or they get paid as a PCSP hourly, period. That's the only way we'll do the program that way. Right now. That could change as things change. The next section we're going to talk about is social community information. This is our alcohol Audit C tool. This is the screening. This is another component that goes along with the PHQ, which is the audit tool. It's shortened. We had a whole page of questions, and now we only have 3. Again, please try to score it accurately as possible and put the total score down. I've given you what the score is so that you'll be aware, so if you have to address it in your needs. Substance abuse, there's no scoring for that, but it just sort of goes along with the other. If you check off that they do have an adverse substance abuse problem, please try to elaborate a little bit in the nurse's note or the needs so that we're aware. We try to give heads up to people when we can about those things. The next section is section N, reported conditions. A key component to this is check only those existing known conditions that relate to the individual's current status. Please don't include their whole health history here. It's not necessary. Only the things that are pertinent to the medical needs. A lot of people want to include all their surgeries and all that, and we don't need to know that. So just what is going to be pertinent for us. If you don't have a place to put it on the checkoff boxes, please indicate it down in other conditions. Balance. This is where I put locomotion and primary modes of locomotion. Falls and fall risk did not change, but you see I've added the other 2 categories underneath question 2. The reason I did that is because it fits more here than it does over with the ADL side. When I was researching for this, I sort of was looking at the types of things that they do, and there's usually about 5 activities that you should be trying to observe while you're in the home doing your assessment. And one is them moving from a seated to a standing position. What is their level of ability to do that? Can they do that, steady at all times, not steady but able to stabilize themselves, or not steady and can only stabilize with human assist? And I tried to, those will be in the instructions so that you'll have them, but that's when we're looking at this to determine, is that person really independent? Or do they need that walker right beside them to kind of help them stabilize themselves? The next activity should be walking with a device if used. Do they take the device? Do they remember to take it? Do they leave it over by the bed or the couch and then take off, kind of wobbly? This one I thought was interesting was turning around. Can they actually turn around? And that would be their ability to manage in the bathroom or in the kitchen. If they can't turn around without becoming unsteady, then that's an indicator that they need some assistance. Moving on and off the toilet. Now certainly, if they don't have to, you're not going to ask them that, but you can get the gist of any of these 5 activities should give you an idea about the stability of their mobility and their balance. Surface to surface transfers. Wheelchair to bed, bed to toilet or whatever. So we're trying to determine their level of ability and how much assistance would be required in that home by asking those questions. And I see they didn't give you the little boxes next to the 0, 1, 2, 3, 4, 5. We'll add those. And then down the assistive devices, it says choose only one. Some people have more than one, so I'm going to have them eliminate that. because you'll be able to, to actually choose either the Hoyer lift, or some people have a scooter, some people have the power chairs. Nutritional status, we didn't change anything in that section. Still the same. And skin conditions is still the same. We have taken out the page that had the signatures on it. We are now to the support plan. The support plan is underneath your nurse's note. The nurse's note will expand down. If you're not able to put in what you need to in the nurse's note, then I need to know that so that we can flip it to the next page. But we were trying to keep it so that everything, the nurse's note was there, short and simple. You don't need to be elaborate. Just try to give us the key points that you need to, and then the identified needs. We tried to put them together so that it would be easier for you. And again, we're reminding you of the PHQ score and the audit score. So that if you need to, that will remind you that you need to put that in your identified needs. All we want you to do is put your name and title at the end of the nurse's note. That's the only thing that you have to do in this assessment now. You do not have to have the client sign it. No, I took everything out on that page. The only thing I left is the identified needs. Because really, this assessment tool is the assessment tool. So we have it on the consent form, so we took all the other stuff off. Yes, ma'am.
Do you ever anticipate that caffeine will go away? You know how we have to ask people if they use caffeine, and they look at you like, who doesn't?
I didn't even really look at that section. That wasn't one of the important ones.
No,
but
no,
I don't know if that, would be one that we would. I mean, I think those have been there for a long time, so I guess we would have to look at those and see if they're really part of it. Yes. Yeah, the power drinks are the ones that we don't want them to do. Yes.
The box for the case manager being present is removed as well. Do you want that noted in our narrative moving forward, or does that piece not?
We would like, at all possible, for the case manager to be present for as many of the assessments as possible.
Yeah.
We just took that out. You can note it if you like in your note, but we would like them to be as many present as possible. Because we're finding that the case management is, when we're saying that, we're looking at the assessment and we're having difficulty with developing a plan or seeing about their eligibility. Case manager sometimes has information that is very helpful on the visits, and that's why we're going to try and encourage as many go as possible. Just because we took out about reviewing the identified needs with the client doesn't mean you shouldn't do it. We would like you to still review those identified needs. They may not agree with all of your needs, or they may say, I'm not going to do that. And we just would like you to note that they were aware, and that isn't something that they want to participate in. That would be very helpful as we're going forward with care planning. Any other questions about the assessment? You should be getting your identified needs from your sections throughout the assessment that you click off.
I think the question I have on the ADLs, The way I was looking at it was for self-performance. I wasn't looking at the number of days. I was looking at, like dressing. They can help to do some of it. Extensive assist, the caregiver had to do the majority of it. And then I would put whether it was that it was a one-person assist. So I wasn't looking at days.
So
at all.
so how would you score that question then, Sandy? Did everybody hear her question? She has an individual that is doing some of the dressing herself, but then the caregiver is doing the other parts that she can't do. So I'm asking her how she would score that.
So I would check off for dressing. I would check off limited assist, and then I would check off one person physical assist. And then in my note, I might tell what part. Lots of times it's the shoes and the socks, and it's because they can't bend over. So I would put that.
But what would you put for an identified need?
Assist with dressing.
Okay. So that's what you would do. If it's, remember, 3 or more times, you probably want to look at what is limited assist appropriate for that person? Is that every single time it's a limited assist? Or on the days they don't have the caregiver, do they not get dressed?
And that's what I put.
And then it would be, yeah. Right. So you would want to put during time with caregiver, limited assist, but days no caregiver available, we don't do it at all. That's what we want to know.
Right.
Because we would put in other services if they needed it. Yes?
On page 8 under risk factors, can you just explain exactly what it means, like by checking each of those boxes? I think specifically is able to make needs known. By checking that box, is that stating that the individual...
Under the environmental assessment?
Yep.
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 Okay.
So under risk factors, by doing a check in that box, are we saying yes? So is able to make needs known. If we check that, yes.
If you check that, then they're able to identify and alert someone to make those needs known. Yes.
Okay, and if it's left blank?
If it's left blank, I just think that it's, there was nothing that you needed to address there.
Okay.
Because they're very specific questions.
Mm-hmm.
So if you don't answer them, I think that they're
That the answer is no.
correct.
Okay,
Correct.
thank you.
It's the next box that's really, we look for that box with all the risks.
So if I checked off is able to make needs known, then I would be saying that person feels threatened or unsafe, but she can make her needs known?
No, you're saying that the person manages by making those needs known, no matter what it is within there.
Okay.
So you potentially could click off all 3 boxes.
You potentially could. Do they live in a neighborhood they feel threatened or unsafe? Are they able to make their needs known to outside parties that they need to? Call the police, call their family, whatever. Because of limited finances, they make trade-offs in purchases of heat, food, and medication in the last month. Any other clarifications or questions? Any comments about the way it's set up, or? Did you say that, Greg? Looks better. Karen? Yes.
Missing boxes.
Page 3.
Page 3.
Hold on.
Sorry, this was last minute. I'm very sorry.
Yeah, no.
Oh, yeah, you're missing a box. Yeah, we'll make sure those get added. Okay, so the other parts that are with your packet, of course, you have the clock drawing, okay? If you're doing community assessments, and/or facility assessments, you might want to download and give the client health information privacy rights, or you do want to, because that's their information that they should have.
Karen, maybe you want to point out that those are going to be included in the,
Oh,
so by clicking on the resource tab, all the
there,
documents are.
Scott has them all for you. So when this training goes live, you'll be able to click on the resource button to see the different documents that relate as you're going through it for other people who want to review it. And he will have everything in there for you. So that is going to be a positive, that you won't have to be searching for the documents somewhere else. They're all going to be with the presentation. So the other one is the authorization for release of protected health information and the combined consent. Now, for a while, we haven't taken that from facilities, but because changes occur, we would like to implement at this time that every assessment comes with a consent and a release of information. Only because if the person goes home and you're looking for CFI, we've never gotten the consent, so we're running around trying to get them, which can be a problem for some of our population who don't return their mail. Even a problem for some of the guardians who don't return them timely. So if you're doing an assessment, no matter what you're doing it for, nursing home, Choices for Independence, just have the two consents signed. They're out there on the site. And if you have to get a guardian or DPOA, if you could help us out by doing that. We're trying to process as much as we can. As long as we have a consent, we'll process. So if we can, because we've taken them off the assessment now. So we have no longer have a signature there. So it's really important. During your visits, you really need to try to make sure that you get those consents done. It's very difficult to chase them after the fact. We're having a hard time.
Sorry, maybe silly, but even if you're inpatient, is it?
Inpatient, yes. The reason I'm saying that is because they're going to want CFI maybe, and so I need to have those consents done. We never had them do them inpatient before, but now there's so much flipping going on with people going for a short stay and then they're coming home on CFI. Without those consents, we can't move forward. So it just makes sense. The other form that you have is called our utilization review form, and this is for our swing beds and our nursing homes. So community people, you don't need to worry about this. But the reason I wanted to talk about this is because it seems to be a little confusion about it that I wanted to review. Scott doesn't have that form, but we'll make sure that we can put it up for everybody. If you are a facility that has swing beds, or you're going to send somebody for a short stay Medicaid to a facility, we only do a 30-day approval. Every 30 days, we must have a utilization review form completed and submitted to the state to make sure they're still meeting that level of care. The state Medicaid system pays for 3 30-day stays under what we classify short stays. Could be skilled, could be rehab, whatever. Once they complete that 90 days, then we go to a 90-day long-term care approval. Those are for our swing beds. For our nursing homes, once they complete the 3 30-day skilled, they go to long-term care. So that is just a reminder to people, because I'm not getting these in timely, and then people are wondering why they're not being able to bill. It's because we haven't gotten these. This is only for medical. This has nothing to do with if you got a shortened PASAR or something. This is only medical. You send your PASAR forms off where they're supposed to go. But I can only put in the dates that I'm supposed to put in. So if PASAR gave you 30 days, that's all you get is 30 days until we get more information. So try to get everything done as timely as possible at your facility. Get it in as quickly as possible. The notice of decisions will probably let you know your date spans and when you need to submit. The last important form. Do you have the change of status stuff? No. Okay. This form has become the most important form of the unit. Without a change of status form, really the assessment doesn't move throughout the system very well. If the person is in a facility and they're going to a nursing home under Medicare, and then the person is going to still come back and join CFI again, we're looking for this change of status notification to know where the person is. It is going to help our community providers greatly. What happens is our community providers get assigned their redeterminations. Well, they try to call and they don't get an answer. And then we don't really know where the person is because we don't have anything in the system to tell us that. So the change of status is important when you have somebody in your facility and you know that they're CFI. You should be letting us know that you're moving them on to the nursing home so that we can let the providers know not to go out and do that reading yet. I hate to have people going out or making phone calls and they can't. You get a little worried when you can't get someone on the phone when they're supposed to be on the program. Also, date of death. This is real important if the person dies, so that we can make sure, because remember, the assignments go out 1 to 2 months ahead sometimes. And if we don't know that, we can't let them know not to try and contact that person. If they're coming in and you're transferring them to the nursing home, you can use the middle block, which says transfer to nursing facility and or CFI to nursing facility. At least you're telling us that they're being transferred so that we can track where this person is. If they're ready to go home from your facility and you want CFI to restart, please fill out the bottom block, discharge to community. This is real important for us so that we can keep track of where everybody is, so that we know. A lot of people are waiting on their discharges for CFI to be in place. As a reminder, if Medicaid is paying any component of that stay, wherever they are, we cannot put CFI services in place. We can have everything ready, but we can't put them in place yet. So we can give you a preliminary plan, but as far as moving them into the CFI provider network, we can't do that yet until they actually discharge. That's why this is so important, so that we know that they've discharged. And we can put the plan in place, put the services in, get the case management assigned, and we can move them through the system. Yes?
So if a patient's in a hospital for a week or 2 weeks or 5 days or whatever, and we know that they have services at home through CFI, we know the case manager, we usually call them that they're there, call them when they're discharged. Does the hospital need to fill this out?
Yes, they do.
So the case manager who's active with them through CFI would...
We have not engaged, they will do it if no one else does, but we have not engaged them to do the change of status because they're not really watching that person. You are, and it's the hospital's responsibility to let us know. Because a lot of times they'll send them to a Medicare stay, and the case manager may not know. So,
right, and we do it during that, but I don't think we're doing it when they're discharged directly home.
And there is some delay with people getting their services because their assessment could have expired. So if the case manager didn't tell you, there's no way services can be implemented without a new assessment. Or it could have been that maybe the person came up on, something happened that their Medicaid closed. They can't implement services. So if we don't know about it, we can't check the case and make sure that it's going to be all right. 9 times out of 10, usually nothing is wrong. Usually they can reinstitute services and they can go along. But it doesn't hurt to do the notification. And then people are notified. I know we had a client that we were trying to contact, and it had been a little bit of time. And we got a call from the hospital and said, oh, yeah, she's been here with us since such and such a day. And it's like, okay, well, as everybody's worried about, where the person is, and actually she was in the hospital. So it makes a
As a
problem.
case manager, we usually will notify the case manager.
As long as you're notifying the current case manager,
Right, which
that
we
is
do.
fine that the person's
Right.
there. And if you're completing this when they go home, it gives us record that the person has gone home and will be all set to put services back in place. Because it's really difficult not knowing, having an expired assessment, something's wrong with their financial Medicaid, or whatever be the reason, and that person can't get those services. So all they have are skilled services when they go home. Any other questions about the change of status? Nothing? No questions? Wow. I don't know if Vicki, you want to talk about upcoming events?
Yep, thank you very much, Karen, you did a great job. Was everybody that's here familiar with the MEA process? I want to talk a little bit about PASSR Level 2. And I do that because we have UMass in the audience today. And I know that when they do the PASSR Level 2 assessment, and some of this comes from the hospital, or from the community, and if you could encourage individuals in the community that are applying for PASSR on behalf of an individual, that they send the diagnosis and any of the medical, but don't send the entire medical record. Because what is happening, and I hear this from UMass, is that they're getting reams of paper because it is the entire record of this client, and they have to whittle through just to try to find, the diagnosis of the client. So this is a case when more isn't always better. And I do know that from some of my experience with UMass is that sometimes they go back and forth with providers to get that medical documentation. So it's clearly extremely important that they get the diagnosis. And I know, we're all busy, and sometimes just sending, especially doctor's office, sometimes just sending all of the medical records is a lot easier to do, but it's a lot harder for UMass to go through and to give you that, that determination so that Karen can put in the medical assessment. So yes, that's important. So I thought I'd say that since I was here. I am the liaison with UMass, and, we do go back and forth. So that's just one of the things that I've seen over the past couple months since I've taken over. But we do have upcoming changes. I mean, there are going to be major changes through the Balancing Incentive Program. We have enhanced New Hampshire Easy. So instead of going out on eStudio and uploading your medical assessment and your change of status. What's going to happen in February, we're going to go live with New Hampshire Easy, and everything is going to be right there in New Hampshire Easy. So when you're with that client via your laptop, you'll electronically fill out that form, and then it will automatically be submitted. No more paper.
Mhm.
Now, enrollment in New Hampshire Easy will be in the next 3 months. As soon as Carol Sedaris, the director, signs off on the memo that's going out, I will forward the memo to everyone and I will put it up in eStudio. What's going to happen is, right now with New Hampshire Easy, you can go out there and look at, we talked about it the last time we were here. You can go out and you can look in New Hampshire Easy and see the case status of your client. Well, there's going to be a new checkbox on that form, and that's going to allow you access to New Hampshire Easy, the medical assessment part of it. Now you'll be able to upload the MEA, the change of status. That is how you will communicate with the unit. You will communicate back and forth. You will be able to look at the status of whatever it is that you submitted. If we have a question, we'll email back through New Hampshire Easy. Your answers, when you ask us, will come through New Hampshire Easy. It'll be one place to collect everything. And eStudio will go down for the MEA and the change of status. We'll still utilize eStudio. We'll use that to send policy updates. We'll have some of the forms out there. Any instructions will be out there. And we anticipate doing statewide training in the month of January.
Excuse me, Vicki.
Yes.
In some of our more rural areas, there is no internet. So there's no Wi-Fi, nothing.
Do they take and put information on a form in their laptop?
You can save the form to the laptop without being connected.
Yeah, and then you'll be able to connect and upload. It's just going to be, actually I've seen the demonstration, and both Karen and I worked with New Heights, who is the one that's creating it, and you will be able to track the status much easier of the forms that you put on. You know, it will eliminate losing things that come to us in fax, because everyone knows that when you get a fax, if there's no paper in the fax machine, or, you know, if somebody has to print something and then scan it into the document, there's always that risk of losing stuff. All of this information will be right there in New Hampshire Easy. Karen and her unit and her staff will have dashboards so that they'll be able to go out there and see what needs to be processed. It'll be much easier than eStudio today, because I know if I want to go out and I want to see if something was submitted, maybe it was a redetermination or an initial, you have to go through all of these folders to find it. It's very cumbersome. It's going to be much better for us. I mean, there will be some growing pains, I'm sure, but it will, in the long run, be much better for us. And we should be able to serve our clients and serve you a lot easier. Has everyone signed up for New Hampshire Easy so they can see the case status of clients or the individuals that were here?
No.
I did not bring the form, but we can certainly provide it. That is it. You guys are going to go home early. Do you have a question? John, do you have anything you'd like to add? Oh, I do. For anyone who's available on the web, if you have questions, you can send them directly to myself at mgrimes, Grimes, at dhhs.state.nh.us. I will collect those, Karen and I will work to answer them, and then we'll send them to Sean. Thank you very much.
Very good.